George was 89. He lived with his wife, who was 87. They lived independently in the community. They had a very good social life. They had very few health needs, and they were fairly healthy. Seldom went to the doctor, and they were just too busy, mainly, to go to the doctor. George was a very keen gardener. He developed a sore knee, began whinging about it, and his wife said, "Oh, we'll do something about it." So he went to his home remedies and tried this and that, continued to whinge to his wife that it wasn't getting any better. "Well, why don't you go to the doctor, George?" "What would he know?" said George. So eventually, to shut his wife up and to stop her whinging, and because he did want to get back to the garden, he went off to the doctor. So the doctor said, "Oh, George, I haven't seen you for a long time." So the doctor's looking at the computer screen and, "What brings you here? I haven't seen you for ages." "Well, Doc, I've got this so-and-so sore knee and I want you to fix it because I want to get back to my garden. I can't kneel on it to do the weeding." So the doctor leaned back in his chair and looked at the computer screen again and said, "Well, George, you are 89. George knew what was coming. He leaned forward in his chair and said, "Well, the other knee is 89 and it's all right." You must not expect to have pain as you get older. What is pain? In all the nursing and medical textbooks I've read, the very best definition is pain is what the patient says hurts. They may not use the language, "I'm in pain," or "my pain is 9 out of 10. They may not even use the word, especially if they have dementia. They might say "ouch" when someone is trying to take their arm out of a sleeve. So pain is what the patient or person says hurts. And of course, you can't see pain. You can't examine it under a microscope. So you can't prove that somebody is actually in pain. And of course, pain has many components: physical, psychological, and spiritual and emotional. And what we learn in holistic healthcare, and particularly as a palliative care nurse, we learn very early on in our careers the impact that pain in one area will have on pain in another area. So emotional pain will impact on physical pain. Physical pain will impact on psychological pain. And so it is a huge area, and it is too complex for one person to say she's in pain or he's not in pain. So, having said, not expect to have pain as you get older, but if you do, and many of course will, and we've already talked about the small minority of Australians who will need full-time residential aged care because of their dependency needs, and many of those people suffer pain. So what are some of the sources of the pain that some older people experience? And I'll give you a list, and you probably know the list, and you probably have others from your own experience. Low back disorders, very common. Degenerative joint diseases, particularly osteoarthritis. Then there's the rheumatoid inflammatory arthritis conditions, gout, Paget's disease, the pain from skin ulcers, and we've talked already this morning about decubitus ulcers or pressure ulcers, the pain from chronic leg cramps or restless leg syndrome, which is often tossed off as something just peculiar to that person, can be extremely painful. Post-stroke syndromes, I went to a lecture recently by a neurologist talking about somebody who's had a major stroke, leaving with them with some hemiparesis or some paralysis, and saying most of those patients will have pain forever. So all of these things need to be taken into consideration when the older person is immobilised for one or another reason, to try and investigate the source of the pain that they may have. Then we have all the other neuropathic pains, the pains that involve the nerve endings, the diabetic neuropathy, the post-herpetic neuralgia or the post-shingle syndrome, I was speaking at a nursing home recently, and they were trying to determine the pain of an older person who was sitting there constantly rubbing her cheek. She had dementia, and people were inclined to say, oh, it's just her dementia, she just rubs her cheek all the time. Until somebody did some investigating. She had shingles about a year ago. Others would say, well, the shingles are gone, there's no rash there, why is she still rubbing her cheek? We know now, we probably didn't know this 5 years ago, that the pain from shingles can remain for 12 to 18 months. So this is just one illustration of how important it is to be like a detective to try and ferret out the source of the pain. And then there's the oral dental pathology, and maybe with her inspiring address, I'd love to take her into every aged care facility in the nation to talk about the implications of misunderstanding the reason for people not eating. Recently, a dentist in Melbourne who was very interested in aged care went into 12 different nursing homes to investigate for himself the state of the oral health of the older people. He was absolutely alarmed at what he saw. Everything from ill-fitting dentures to fungating mouth ulcers that had never been treated because they had never been diagnosed. The older person not necessarily able to tell somebody that they have a sore mouth. Nobody had got a torch to shine in the person's mouth. So what happens? The older person moves their meal tray away, because who wants to eat if you've got a mouth ulcer or if your mouth is sore? And we heard from Maggie Beer that 50%, the statistics that 50% of older people in residential aged care are malnourished. That's an amazing figure in 2014 in Australia. But much of it is because nobody has tried to investigate the source of the older person's pain. Then we have the pain from angina, we have pain from constipation, which is one of the most serious painful conditions, particularly in somebody dying with cancer or other terminal illnesses. We have the pain from just from immobility. When I say just from immobility, if you're not able to turn yourself over in bed or shift your position in a chair, you will have pain, will you not? By the morning or by 2 or 3 hours' time. And if nobody has assisted you to change your position, you will be in pain. We know now from all the research that pain post-fracture can last for months and months in the older person. So you send the person off to hospital with a fractured femur, it gets fixed, they come home or back to the nursing home, but they still have pain, and from the moment they're discharged from the hospital, they're not on any painkillers. So they have persistent pain that goes untreated. There is the pain from gastric reflux, which is very common, and then there is the increasingly common pain associated with mood disorders. And we know the increasing prevalence of depression in older people, and particularly those in residential aged care, which is not treated because it's not diagnosed. And we know that pain, when it's not treated, can lead to depression. So what are some of the responses to pain for any of us? And if we had the time, it would be interesting to have this discussion. What do you do when you're in pain? Tell the whole world? Keep it to yourself? Go straight to the doctor in case it's something serious? Or never go to the doctor in case it's something serious? Or what else? So what's your response when you have pain? You turn the music up loud? Do you turn the music off? Do you look for company? Do you lock yourself away by yourself? You tell nobody? You tell everybody? You diagnose yourself via the internet? Or you hit the pill bottle? Or the other bottle? Or do you keep your upper lip stiff? And there are many and various attitudes that researchers have gone into to try and understand the attitudes of older people in particular. And you'd be familiar with those attitudes. I don't want to make a fuss. Or the nurse is doing the drug round with the medication trolley. I don't know, I'm all right, dear. You go on to the next person. The fear that you won't be believed, or that you're neurotic, or a chronic whinger. And it's interesting to note now from the World Pain Association that there is a move to away from the term chronic pain with a preference for the term persistent pain, because chronic seems to have often associated with a pejorative interpretation. Oh, she's a chronic whinger, or the pain's chronic, there's nothing I can do about it, just got to learn to live with it. So if we learn to talk about persistent pain, perhaps we would be more persistent about trying to find the cause of the pain and then trying to relieve the pain. So people who are afraid of being labelled as a chronic whinger will not necessarily report their pain. And then you hear things like, it's so humiliating. You can't keep up with your fast-walking friend, so you pretend to stop at every shop window. How common is that? Or it's so limiting. I can't hold my grandchild's hand anymore because I need both hands on my walking frame. Or it's exhausting. I'm constantly tired. And I can't even bear to go out because I'm so tired. Or I don't want to be a burden, so I won't say anything. Or I don't have any right to complain, there's plenty others worse off than me. So what are some of the features of persistent pain? Because it is very, very common. My understanding of the latest research indicates that 80% of residents in aged care homes have pain. And even more startling than that piece of research is the analysis that 80% of people in residential aged care have pain which is untreated because it's unrecognised. So it is a very, very important and a very, very worthy cause for us to spend just even a few minutes focusing on. One of the things that I constantly try to teach nurses and carers in aged care homes is to avoid the phrase, he doesn't look as though he's in pain. So we have nurses perhaps in a handover session or discussing with one another or with the doctor, oh, I think George is in pain. Oh, I don't think he's in pain. He just rubs his knee like that all the time. Or, no, I don't think she's in pain. She doesn't look as though she's in pain. To make that judgment shows a complete lack of understanding about what persistent pain is or what pain is generally. If you have acute pain, which might be as a result of gallstones, kidney stones, appendicitis or angina, heart attack, you will look as though you're in pain, or mostly 99% of people will look as though they're in pain. So a nurse or a health professional can pick it from the emergency room doorway. The person is writhing, guarding their abdomen, might be pale, sweating, might be calling out in pain, and if you check their pulse and blood pressure and respiration count, you'll find that they're all over the shop. That's acute pain. And in a sense, while it's certainly not easy for the patient, it's easy for the surgeon to whip out the appendix, for the dentist to pluck out the tooth. And so that can be fixed, not overnight, of course, but acute pain can generally be fixed because there's a cause and you can usually treat the cause. But chronic or persistent pain is not so easy to see. And one of the reasons for that is there are no what we call autonomic signs. In acute pain, the autonomic signs are that your blood pressure and your pulse rate will alter, you might be sweating and you might be pale, because they are autonomic signs over which you have no control, because the pain is affecting your body in the way that it elicits these kind of symptoms that can, as I said, be seen from the doorway. But chronic persistent pain is not like that. And for many older people, if I just sit here and I don't move and I'm all right and nobody touches me or comes near me, I'm okay. And I won't look as though I'm in pain. And therefore, I won't cause a fuss. But you come with me with that lifting hoist and try to get me out of my chair and onto the toilet or into the bed, and then I will scream out with pain because I can't help it. But while I'm sitting still or lying still, I can bear it. That is no excuse for any health professional to ignore proper pain control for that person. Just because they don't look as though they're in pain doesn't mean they're not in pain. So pain can be very, very isolating, as you would all know. You would all have known of people who say things like, I just can't go out because I just have so much difficulty even getting up and down the front steps. Pain can be isolating for those in aged care homes as well. So what should we do if we even see a hint that an older person is in pain? And this is for anyone living in the community or anywhere. You try to seek the cause of the pain. You badger your doctor for trying some regular painkillers, which may be just to use as a trial at first. Let me try some regular Panadol or paracetamol. And this is a very, very important thing to recommend for people who are in aged care homes. Let's try 4 grams, that's 8 tablets of paracetamol every 24 hours for 1 or 2 weeks and see if it settles the pain. That can be used as a diagnostic tool. And if it works, voila, we have identified not necessarily the source of the pain, and a mild analgesic like that has no ill effects on 99.9% of the older population. So it can be given safely without any side effects. But the problem is many older people wait until the pain gets really bad. Well, it's not time for my next tablet yet, so I'll wait and grin and bear it. That's not good pain management. The way analgesics or pain medication works in the bloodstream is that the pain is here, the analgesic or the painkiller is here, and there must be sufficient painkiller to meet the pain so that there is a steady state in the bloodstream. If the pain increases and the analgesics do not increase, then you're going to get out of kilter and there won't be a steady state. And the only way to keep a steady state in the bloodstream is to have regular pain medication. And usually starting low and going slow is the mantra. So pain has a purpose. Pain is telling the body, telling us that there is something wrong. We are increasingly alarmed, as I said, about the number of people in aged care homes in particular, but those who are living in the community as well, because people don't believe them or they're not quite sure, they don't want to get hooked on painkillers, or for many other reasons they don't report their pain. But we're dealing with chronic persistent pain which never goes away, and so the painkillers should never go away. Persistent pain needs persistent management, and that doesn't mean a Panadol here, 2 tomorrow or 3 tonight and none tomorrow. It means a regular amount. And the aim of good pain management is to improve the person's function. Pain in dementia is a particularly urgent issue. We know statistics you read. 60 to 80% of people in aged care homes today have dementia, and many of those people are unable to report their pain accurately. So sadly, we hear aged care workers, and to my shame I hear nurses say this, oh, she just screams like that all the time, it's her dementia. Or a nurse said to a student nurse, just ignore him, he does that all the time. It's just one of those things about dementia. Well, that is an outrageous comment to make about somebody who was screaming out, not for the fun of it, but because they're in pain and they lack the words to tell us where it hurts. So that's a particularly important area that I can certainly not do justice to in 1 or 2 minutes. But the question of being alert to a person's pain, and particularly if the person has dementia, what I try to teach nurses is you don't just look at the person when they're sitting or lying. A proper pain assessment will judge that person's pain when they move from the chair to the bed, from the bed to the toilet, when they're eating, when they're sleeping. These are all the time, so pain assessment really should continue right round the clock. Just to close, a quick story. Marjorie lived in a nursing home. She had osteoarthritis. She used a walking frame. She needed 2 people to transfer her. She was unable to stand alone. She was depressed. She walked with her head bowed to the floor. She often refused her meals. She often was reluctant to get out of bed. One of the more sensitive nurses said, let's try her on regular paracetamol. It had some effect, but not very much. So in discussion with the doctor and her family, a very, very mild opioid was added. That is a strong painkiller that can be given in a very small amount via a transdermal, via a patch. So that was added. After 4 weeks, Marjorie can stand alone for a few minutes. She only needs 1 nurse to transfer her and assist her to walk with 1 walking stick. Her appetite is improved. She stands erect with a smile on her face, and her family can't believe it's the same person. It can be done, and it should be done more often. And when the pain cannot be entirely eliminated, we go to that famous author, Anonymous, who counsels to cure sometimes, to relieve often, to comfort always. Depending on which statistics you read, 60 to 80% of people in aged care homes today have dementia. And many of those people are unable to report their pain accurately. So sadly, we hear aged care workers, and to my shame, I hear nurses say this, oh, she just screams like that all the time, it's her dementia. Or a nurse said to a student nurse, just ignore him, he does that all the time. It's just one of those things about dementia. Well, that is an outrageous comment to make about somebody who was screaming out, not for the fun of it, but because they're in pain and they lack the words to tell us where it hurts. So that's a particularly important area that I can certainly not do justice to in 1 or 2 minutes. But the question of being alert to a person's pain, and particularly if the person has dementia, what I try to teach nurses is you don't just look at the person when they're sitting or lying. A proper pain assessment will judge that person's pain when they move from the chair to the bed, from the bed to the toilet, when they're eating, when they're sleeping. These are all the time, so pain assessment really should continue right round the clock. Just to close, a quick story. Marjorie lived in a nursing home. She had osteoarthritis. She used a walking frame. She needed 2 people to transfer her. She was unable to stand alone. She was depressed. She walked with her head bowed to the floor. She often refused her meals. She often was reluctant to get out of bed. One of the more sensitive nurses said, let's try her on regular paracetamol. It had some effect, but not very much. So in discussion with the doctor and her family, a very, very mild opioid was added. That is a strong painkiller that can be given in a very small amount via a transdermal, via a patch. So that was added. After 4 weeks, Marjorie can stand alone for a few minutes. She only needs 1 nurse to transfer her and assist her to walk with 1 walking stick. Her appetite is improved. She stands erect with a smile on her face, and her family can't believe it's the same person. It can be done, and it should be done more often. And when the pain cannot be entirely eliminated, we go to that famous author, Anonymous, who counsels to cure sometimes, to relieve often, to comfort always.